thank you very much. And to close this session, we will welcome the three speakers for the interview. Our chairman, Professor Claudio Ronco, Dr. Francisco Roberto Ramirez, Lara, and Dr. Rudy Suprayadi. Please come to take a seat.
Thank you for joining us at the end of this session. I think that the presentation has been quite interesting, and I'm an intensivist, so I'm more used to deal with acute disease. But I see that there is a large field of application of hemoadsorption and extracorporeal blood purification also in patients with chronic diseases, in particular with a renal chronic disease. So can you please comment on this?
Yes, thank you. Dr. Francisco Ramirez. I am from Monterrey, from Mexico. And first of all, I want to say thank you to Jeffron to make the invitation to participate, sharing experience today with you. And from experience, now we are making more than 400 treatments for HA-130 in patients in the northern Mexico. Sometimes the patients, we know that we are having complications for long-term hemodialysis, and the patients are they have inflammation, and these patients improve several factors like hypertension, decreasing hypertension, diminishing levels of PTH, and also improving numbness and all kind of several complications. One aspect that I see in some patients when for some reason the politics for reimbursement or insurance in Mexico, sometimes they need to stop the treatment because they cannot afford the treatment. So when we stop the treatment, the patients go back to the other symptoms. So it's clearly to the cartridge, the absorption for this product, they benefit and they feel better than when they use it. So for me, it's, this use is very, they have better outcome.
Yes, yeah. Please, Professor Supriyadi is from Indonesia, and he comes from West Java, Indonesia, and he is Chief of Internal Medicine Study Program at the Medical Faculty of Adijaran University. So please, can you comment?
Thank you. And first of all, of course, thank you for Jeffron for inviting me to this international meeting and amazing meeting, and especially that this is an honor for me to can sit on the stage with my idols here. All the professor and the expert are my idols, especially Professor Claudio Ronco that we have met few times in Bandung, West Java, Indonesia. But maybe he forgot because I'm just still a young student a few years ago. And then it's very honored that now I can sit with my idol here side by side. Okay, back to the Javron and my study is especially in the inflammation, stress oxidative, and the antioxidant and malnutrition. I'm a nephrologist, but a lot of my study is on those fields. So when Javron met me and they introduced me the cartridge, maybe this will be the method that can be matched with my fields with inflammation and stress oxidative. Now I have pilot study in Bandung about all of that using the we're using the Javron HA130 that will search for another view from Dr. Jonny has stated before that we will see maybe around next year. So there is some view that Javron, especially in 130, on 230 and 330 cartridges that we want to study, we want to search in deeply, yeah, because you know in the chronic diseases such as renal disease patient, there is a chronic inflammation state that always bring the patient to the worsen condition, include the mortality of cardiovascular death and the decreasing of the quality of life because the inflammation and the stress oxidative. And we will see about that after the study has completed. Okay, thank you.
Yeah, Professor Ronco doesn't need any presentation. So.
Just to meet your expectation of an intensivist, in the past years, you used a term which was SIRS, Systemic Inflammatory Response Syndrome. Well, we discovered that uremia is a slowly progressive SIRS. This morning, I mentioned the concept of smoldering inflammation. It is a subclinical status of inflammation that was detected in the moment we could measure CRP with high sensitivity. And we discovered that within the detection limit of high sensitivity CRP, there is a continuum that correlates with outcome. So this is a very important aspect and makes the rationale not only for the removal of uremic toxin, but as I mentioned this morning, makes the rationale for the removal of inflammatory components that are in part responsible of generation of uremic toxins. So it's a kind of vicious circle that you can somehow block, removing in part inflammatory mediators. Concerning the results, I showed the decrease in beta-2 microglobulin, and beta-2 remains stable even though you use one session per week. However, I must say that we don't use 2 hours as Renoualou has presented before. We use the entire 4 hours, and we use blood flow, which is a little higher, so in the range of 300, 350. The cartridge tolerates perfectly because tolerates a flow up to 700 ml per minute, and the duration, in my view, is justified not only by the fact that still the sorbent has some efficiency, but also by the fact that you don't want to interrupt the treatment to substitute the lines, make an increase in the working load of the nurses, etc., etc. So I think that more data probably will be generated in the months to come.
Yes, the most important point is probably to reduce the cardiovascular risk at some weeks or months, and this is probably very important to focus on this for the public health and the reimbursement of the treatment. And because if we are able to decrease the cardiovascular risk at 1 year or 3 years or 5 years, this can have a real impact on the financial trajectory of the chronic patient.
Yes, but Olivier, in order to detect this signal, you have to homogenize the population you are studying. Otherwise, if you compare somebody who has been in dialysis for 15 years and somebody who started dialysis last month, is very, very difficult, and you have the risk to compare apple and oranges. I think that we need to study homogeneous data, stratifying for baseline risk, and based on the analysis of the baseline risk, we can see if there is a chance to reduce the cardiovascular risk. To move from the rational to the practical effect, to the clinical effect, to the long-term effect is a long story. For many of the interventions we do in dialysis, we were not able to show that in the past. Nevertheless, as I said before, in many occasions, we could not demonstrate for bicarbonate dialysis versus acetate. We could not do this for high flux versus low flux, hemodiaph filtration versus non-hemodiaph filtration. But would you like to be dialyzed with cuprofen and acetate today? For sure not. So I think that there is some kind of self-evidence that takes place when you use a technology for a long time.
Thank you very much. I'm afraid that we have to close the session due to time constraints. So thanks to the expert, I invite the speakers to the podium.
Yeah, for the certificate.